And Dr. Kublal, if you're there, will you be having a video presentation as well, so we see you on the webcam?
Oh, I'm so sorry. My video doesn't seem to be working. Is that a
Okay.
problem?
No, it isn't.
Okay.
Dr. Kublal, if you're there, will you be having a video presentation as well, so we see you on the webcam? Ignore that.
I'm so sorry. My video doesn't seem to be working. Is that a problem?
No, it isn't.
Okay.
Here we go. Dr. Bischoff, we are live now, just so you know.
Perfect.
Dr. Kublal will not have a video presentation. She'll just have her voice. She'll share her screen, and just have her voice.
That is fine.
Dr. Bischoff, I seem to have trouble now getting our case number 2 presenter here.
Okay, if that's the case, then we just advance to Dr. Santos' case, and I have an extra case that I can present,
Okay,
so we should be good.
just in case.
Yes. We'll start in 3 minutes.
Good morning, Dr. Pena. How are you?
I'm doing very well.
Excellent.
Good morning, everyone, and welcome to our International Colorectal Web Meeting. So far, we have identified pediatric surgeons joining from Uruguay, Romania, Nigeria, Trinidad Tobago, Bosnia, Mexico, Iraq, and Czech Republic. If I have not mentioned your country, please type in the chat, and we're gonna acknowledge at the end. I already see United Kingdom and Chile. Thank you very much for joining us. The first case will be presented by Dr. Sofia Kuplal from Trinidad and Tobago. Welcome.
Thank you very much. Good morning. I'm just sharing my screen.
Perfect.
Thank you. Good morning, everyone. And I bring greetings from Trinidad and Tobago, from the Department of the Eric Williams Medical Sciences Complex. We are a small unit of 12, and I'm here to present a case on behalf of the entire department, which is a complicated pull-through procedure. So in 2019, we referred a case BC referred at day 2 of life, who presented with vomiting, all feeds, and abdominal distension, with x-rays that showed dilated loops of bowel. And we had a provisional diagnosis of Hirschsprung's disease, and we started managing the patient with rectal washouts. That unfortunately yielded temporary and an inadequate decompression, and the decision was made to therefore proceed with surgical decompression. So the plan at day 7 of life was to do a leveling colostomy versus a primary procedure. At laparotomy, frozen sections were taken from the peritoneal reflection at 10 centimeters and at 15 centimeters above the reflection. And the histology confirmed that there were no ganglion cells at the peritoneal reflection, but ganglion cells were present at the 10 and the 15 centimeter marks. Of note, the transition zone was noted at the 10 centimeter level, and irregular Taenia coli was seen. So at this point, we wanted to ask everyone, would you attempt a primary pull-through procedure at your institution? Yes, if your institution is well supported for this, or no, I will not attempt. Okay, so it looks like the majority of our audience will attempt a primary pull-through, and I'm going on the assumption that that means your institution supports the procedure. So our decision at the time was to do a Suave procedure, and that was performed at the 15 centimeter mark. The distal resection was done at the peritoneal reflection at the point of the original biopsy. A rectal seromuscular cuff was fashioned, and we were left with a non-sutured 4 centimeter bowel external to anal verge, which was tension-free. So my other question would be, what is your definitive procedure of choice out of the 4 options given here? Okay, and we seem to be divided. And the least favorite is the Duhamel procedure, which is ironic because that's actually our preferred procedure in Trinidad. That's good to know. Thank you. Unfortunately, as we continue on day 2 post-op, there seemed to be non-viable bowel at the anal verge. I have a picture at the next slide, but basically we attempted a revision. We found that the revealed necrosed bowel was exactly at the puborectalis sling. The residual sigmoid and the lower descending colon were mobilized and were covered in a moist sterile field to assess viability. However, after half an hour, the distal segment appeared dusky and threatened, and amputation to this limb was formed at the level of viability. An end stoma was therefore fashioned at the distal descending colon. And this is just a picture of the obvious necrotic bowel seen at the anal verge on day 2 post-op. A silastic urinary catheter was used as a stent, PR, to keep the distal rectum patent and to encourage epithelialization. The parent was taught how to do DREs daily at home. and a referral was made to an international specialist center via our telehealth mode. Unfortunately, this was unsuccessful for a number of reasons, but mainly because it coincided with the COVID-19 pandemic, and we had strict travel restrictions for 2 years in Trinidad. And also, the parents couldn't afford the procedure, and at the time, there are actually no local funding institutions that can finance the surgery abroad at the moment. So currently, the patient is now 3 years old. She's well. She has a well-functioning endostoma. She is gaining weight. Unfortunately, the international referral is still not viable. The patient is verbal and she is cooperative, but she's very aware of her condition, and the social implications here is that she gets bullied now at school about her stoma. She can be uncooperative when it's time to do examinations, in particular the PR exam. So for the purpose of our discussion today and moving forward, we did a colostogram last month where we inserted an H French catheter and we inflated the balloon. Well, just to remind you that we have an endostoma here and not a loop. So we had to do the colostogram PR. We performed it with UltraVist, and we managed to get images with just 20 mils of a 50-50 solution, where we were able to visualize the rectal pouch with adequate distension. And then the catheter bulb was deflated and more solution inserted so that we could possibly see a queried stenotic segment distally. And we also put some UltraVist through the stoma itself just to visualize the large bowel, which appeared normal and adequate. So we have a couple of pictures of the colostogram, and I apologize if they're not the best pictures, but it's what we could do, at least get PR. So we have the AP and lateral views. You can see the Foley bulb inflated. And actually, you can see a nice pouch in this picture here with a possible stenotic segment, which was difficult to assess there. I hope that was helpful. I'll play it again. Okay. And we had to do an examination under anesthesia as well for her, and we found that she had a healthy pink and functional stoma. She had a lot of mucus PR, and on the EUA, she had clinical evidence of a pouchitis. However, the DRE was easily performed and admitted a Hagar 16. The anal rectum was not stenosed or fibrotic, and the rectal pouch was measured to be 5.5 centimeters up to the anal verge, and the anal sphincter itself 2 centimeters. And on proctoscopy, we managed to visualize pink, healthy appearance of mucosa, and anal columns were seen. And hopefully you can see, well, you see the evidence of the pouchitis to the contrast study and the mucus collecting in the pouch itself, because this happened over about a period of a week. And then the proctoscopy findings where you can see the anal columns and the pink healthy mucosa. So just to recap our challenges with this case, an urgent need now to make a decision about the next step, as the patient is now 3 years old. And our issues are that we actually have minimal surgical experience in both salvage procedures as well as transanal approaches. If we were to refer this patient again to an international specialist center, at the moment, there's no or limited local funding. And of course, the ongoing social issues as the patient gets older. So the main questions of the day would be, what would be the surgical salvage options for this patient? And in particular, would a Duhamel procedure be most suitable now in this case? If so, or if not so, what other information or investigations may be required? And do you all think, from what I've said today, that this definitive surgery can be performed locally, or do you agree with re-referral to another international specialist center? Would that be more appropriate? And how can we go about getting this done? Thank you very much for your time.
Thank you very much. If there are any questions, please type in the chat and we're gonna address them. I'm just gonna make a few comments. Number one, this is a rectal sigmoid Hirschsprung, so it would be the most common type of Hirschsprung disease. And those patients, they should receive a correct operation the first time. I think in this case, from what you showed us, this patient still has potential to be salvageable and to have a good quality of life, as I'm assuming the anal canal is intact. So in terms of what studies I would like to do if I had to reoperate on this patient, I would definitely have a proximal colostogram just to confirm that I have all the rest of the colon intact for the next pull-through that now cannot fail. It has to succeed. And I think when I saw this case, when I saw the PowerPoint, it kept me thinking, how can we make a true impact in Trinidad and Tobago? And you were very honest to say that your team does not have experience with reoperation and with transanal approach. And I think this offers a wonderful opportunity for training and collaboration. So I will reach out offline because I have a lot of ideas of what we can do, but certainly involving the government and explaining this little girl needs help. And with helping her, we'll be helping many more patients by everything that we can learn. The key in those surgeries is to be able to study and understand the blood supply. Because in this case, we're gonna be in a laparotomy, we would be able to show you exactly the entire arcade and how we have to select the vessels to have good blood supply for the segment that will come down. So I think this would be a case excellent for the team to learn. And I'll be reaching out to talk to you. Do you want to comment?
Yeah.
Thank you.
To extend a little bit on what Dr. Bishop just said, I think this would be an ideal case for the patient and you or a member of your team come to one of a colorectal center that could be in our center in Denver, Colorado, could be in Mexico City or in Puebla, Mexico. There are several colorectal centers, and by reoperating on this patient, will improve the quality of life of this little girl. It's a girl. And also you will learn many things that will benefit other children in your country. So it's not just one case. It was something that is extremely valuable for the future of many children. But that would be ideal if you could convince the government authorities of the importance of doing this for the benefit not only of this girl, but many other children. In some countries that they have similar problems, mothers decided to become leaders, and they promoted campaign to gain to make money. They put together several ladies, several mothers concerned about the management of the children, and they raised money making raffles and selling water in outside and doing parties and to raise money to bring this particular girl either here or to other specialized center in Mexico, and by coming with the pediatric surgeon and preferably with a nurse. So when you go back to your country, you will be able to benefit many children. In this particular case, as Dr. Bishop said, we still need more anatomic information about this case. We saw the contrast material in what seems to be the original rectum and in blind, but it looks like there is a big distance between that rectum and the sacrum. In other words, what is there between that piece of rectum and the sacrum? Perhaps it's a piece of bowel that you pull down. For that, we need a distal colostogram, inject contrast material through the stomach that goes distal to see what happens.
There is no distal stoma.
There is no distal stoma. Then we need an MRI study to see what's there, and also examination under anesthesia. There is a piece of rectum there. Is there a window communicated with another piece left there? We don't want to leave pieces of mucosa in that space because that will give trouble to the girl.
Thank you very much. Even though the photos weren't there, we did do the proximal part of the colostogram, and we're quite satisfied with that. It's good caliber and length.
Okay, good. And there is one more question here in the chat. Let me see if I can open up. With the first Soave operation, the mucosal lining would have been removed down to almost 1 centimeter from the dentate line. Somehow I cannot see the question. Ray, can you see the question? I cannot. Okay. Is it now possible to have a pouch with mucosal lining? I don't understand. What is the question?
This is Mr. Khan. He is one of our consultants in our unit. So we were just wondering as well, since we didn't have mucosa lining, it would have been stripped. We didn't understand how it was possible to have such a robust pouch now with what seems to be adequate and viable mucosa. We weren't sure exactly how that came about. We're happy for it, but
yes. So what I would think is this was a procedure done through the abdomen.
yes.
So maybe you were higher than what you thought, that you were not as low as you thought. That's why you have a distal rectum now. That would be my thought, because this procedure was done through the abdomen.
Okay.
So there is a question, there seems to be a good rectal pouch, and I think this remains to be confirmed. Why not bring down the colostomy on a Duhamel procedure? So again, there are different types of surgery for Hirschsprung disease. Duhamel is not our preferred approach. We like to do a transanal Swenson, full thickness. But if the person doing the surgery has more experience with Duhamel, obviously this is an option. But I think the key for any type of technique that you choose will be to have good blood supply of the segment that you decide to pull through. Well, thank you very much, and I'll reach out with some ideas on how to bring this patient.
Excuse me, Dr. Bischoff, there are 2 more questions in the Q&A. Did you see those?
Okay, no. Let me see. Do you biopsy the neorectum? I think it may be fine and you could close the ostomy. So I suspect that that little piece is the old rectum, and it's the native rectum, let's put it that way. So If there is question about viability tissue, I think it's a good idea to biopsy, and we will hope that it's aganglionic if it's the original rectum. Was there not consistent operative finding of compromised marginal artery? I think this is a question regarding if during the operation you noticed that the blood supply was not good.
No, that was not the case.
Okay. And the question from Dr. White, why not just closing the colostomy? My understanding is this patient has a Hartmann pouch, so it's a tiny piece
Yes.
of rectum and an end colostomy. So it would be a new pull through of the colostomy. Okay.
So then I suggest to open the Hartmann pouch. We never do Hartmann pouch because we need the distal stoma to do contrast studies.
But it's too low. There's no way to open. It's just a tiny piece of rectum.
That's all.
Yeah, that's just what they showed in the contrast study. There's no way to open his stoma. It's this. So now I think the second presenter was unable to join us. So we're going to move to the next case with Dr. Carla Santos from Mexico. Welcome, Dr. Santos.
Good morning. Good morning. Today I will present a 5-year-old male patient with Hirschsprung disease who had a bowel obstruction in the neonatal period and who had the following procedures at the referring institution. 1. Laparotomy plus bowel resection, ileum colonic anastomosis. Here we suspected that the bowel resections include the ileocecal valve. Then, the patient needed a ileostomy because of bowel obstruction. 3. Months after the ileostomy was closed, the child developed abdominal distension due to bowel obstruction. 4. He required a new bowel diversion with a 2 stomatas ileostomy. The surgeons decided to do rectal biopsy that was reported aganglionic. Months after, he underwent a neolaparotomy with colonic mapping, biopsies of sigmoid, descending colon, and appendix in 2018. Finally, a partial colectomy with a Duhamel pull-through was performed in 2019. This pathology, the motive of the sending is rectal stenosis. The pathology samples were reviewed and the results were that sigmoid was aganglionic, but the rest of the samples show ganglionic cells. The child did allow anorectal dilations. We could not assess anorectal patency at clinic. We ordered this contrast study through the distal ileostomy. We can see the rectal stenosis, but show 2 routes of intraluminal paths where the contrast medium passes through. One that continuing and another looks like a fistula. This is the lateral view, and you can see the continuity of bowel and the leaky escape. This is another image. We can same findings. After we review this image, we perform an exam under anesthesia in the operative room, with the following findings. The anus was stenotic, only at the skin level, but after dilating it, only at the we could explore the rectum. The pectinate line was preserved. The rectal mucosa was very inflamed, friable, We observe a rectal stenosis 7 centimeters above the pectinated line when we tried to pass a Higar 9. We took a rectal biopsy 3.5 centimeters above pectinate line. This rectal biopsy was a ganglionic. We decided to do a total prep and begin the rescue operation in the prone position with a transanal proctectomy and continue later one with a laparotomy. First of all, we dilated the rectum and placed the long star retractor. We visualized the pectinated line, another and 1 centimeter above it, we place multiple stitches in the rectum for traction and start the dissection with electrocautery. We managed to dissect the rectum completely, and both a palpable fibrosis 7 centimeters above the initial incision didn't allow us to continue. So we turned that patients over and performed laparotomy. We could see the native rectum. Okay, we can see the rectum nectum and the distal colon. The previous anastomosis to the rectum is here. The native rectum ends in the blind sac and had adhesions to the distal column. In this picture, you can see the native rectum, the distal column. You can see that the colon is very short. It's practically only the second. We took the colonic biopsy at this blue point, and the pathologist observed ganglion cells. We disinserted the distal colon. We also released the adhesion of the rectum to the intestinal segment. In this slide, you can see the clinical picture and the correlation with the contrast study, as well as with the diagram. After completing the proctectomy, we performed the colon pull-through and suture the colorectal anastomosis with Vicryl. Rectal dilations we carry out with Hegar dilator 14 days after the operation until reaching Hegar 16. This is the distal contrast study after the rescue operation prior to ileostomy closure. Months later, we performed the end-to-end ileal anastomosis. The postoperative period was difficult because he developed bowel obstruction, failing to nasogastric descompression, and he required a reoperation. During surgery, we observed that the distal ileum was narrow and with poor compliance. We could advance bowel continent through the anastomotic site. It patent, but high pressure was required, so we decided to resect the distal segment of the ileum and make anastomosis between what would be the site, the proximal stoma and the distal colon. This line represents the peritoneal reflection. This X-ray film was obtained during that hospital state and after the resection of the structures and the new anastomosis. This X-ray was done 1 month after last operation. He passed his stools 4 times a day. The perineal dermatitis was resolved. Thank you.
Yeah. Thank you, Dr. Santos. Any question from the audience? I think I'm going to emphasize this was also initially a good and common Hirschsprung case that unfortunately was managed in another institution and then later came. And when we are doing re-operations, it's very hard to restore the original prognosis. This was a patient that had only sigmoid ganglionosis and ended up almost as a total colonic ganglionosis with a very short piece of colon. So congratulations on the success. Those reoperations are not easy, but I'm glad that the patient is doing well. Want to comment?
Yes, well, Dr. Carla Santos always impresses us because of the kind of cases that she receives at her institution. And but it's extremely important that when you see one of these cases, Carla, hopefully you could send a letter to the doctors who operated on the patients before and invite them to your institution so they can watch you doing these cases. That's very important. Otherwise, you spend your entire life seeing more and more of these cases. You mentioned that the patient has 4 stools, 4 bowel movements per day. The question is, are those bowel movements voluntary or has no control?
Voluntary, Dr. Peña.
Congratulations for your success. It's a great job. You always present these kind of cases, but you are doing a great job taking care of these cases.
Thank you.
And I know many people in the audience would not know, but Dr. Carla Santos works at the institution that Dr. Peña used to work, and that's where he did the first posterior sagittal approach. So it's not an unknown institution for him. He knows it very well, and we're so proud that Carla is the one carrying the flag. Let me see if there are any questions. I think everybody's just saying great case, and there are no questions. Yes, so we're gonna move to the next case. Dr. Santos has another case. I'll mute my microphone.
In the second case, I will present to you 15 years old female patient. He had a severe constipation for the last 9 years, up to 1 week without bowel movements. She received multiple treatments such as osmotic and stimulant laxatives, enemas, rectal irrigations, coursing with chronic abdominal pain. She had a urinary symptoms as well, including frequent micturition, date wetting, nighttime wetting, and sensation that the bladder was always full, with urgency and straining to urinate. The patient had many approaches by multiple services. She had endoscopy, colonoscopy, angiotomography, electromyography, and immunological assessment too. In this X-ray, you can see the fecal impaction. This is the initial X-ray with us. The contrast enema show a colon not dilated with austration. We don't see abnormalities. Tether cord was ruled out. We treat her initially with a stimulant laxative with dose of 17.2 milligrams of senna. After disimpaction, she had abdominal pain. She referred it's unbearable with vagal reaction, hypotension, pallor, tachycardia, and no bowel movements. We tried it in multiple occasions and multiple doses. Rectal irrigation for 1 month were successful, but no later one. Finally, the rectal enemas were successful. Urology service applied botulinum toxin at urinary sphincter and show improve the bladder symptoms. We thought that the botulinum toxin in the rectum maybe was a possibility for treatments but the manometry showed a basal pressure of 21, maximum contraction pressure in 142, relaxation when straining, conclusion, hyposensitivity, inhibitory reflex present but abnormal because present from 50 milliliters of volume. Even so, we decided to take a rectal biopsy to rule out Hirschsprung disease, and we applied botulinum toxin about the dentate line. But the gastrointestinal symptoms persist. We proposed a Malone procedure because the enemas were successful. At laparotomy, we observed a very short appendix. The patient had overweight and length of the abdominal wall was 11 centimeters. The second wasn't wide enough to raise a flap. We thought the flap should be to anterior and posterior face of the second, or could be a diagonal flap. We decided to perform a diagonal flap. The arterial irrigation of this flap was good. Then we create the anti-reflux mechanisms. We decided to place the new Malone stoma in the right low quadrant because the length of the conduit could not reach the umbilicus. The pathology report of the appendicectomy specimen showed a well-differentiated neuroendocrine tumor with low mitotic activity. Follow-up showed ischemia at the stoma during the first days after surgery. We applied hyaluronic acid. You can see the course. At the entrance of the new Malone conduit has a structure and need to extend it with a follow catheter. Despite the fact that it is flared, it presents stenosis in the subsequently healing. We keep the Malone with a follow catheter. She asked for a skin level device, but a Mickey button would be too short because longer is 4 centimeters. She is very happy with antegrade and enemas, daily bowel movements after enema, no fecal accidents, no soiling, no abdominal pain, no urinary symptoms. She had 18 months after apply Botox. But do you know any device to keep the orifice of the new Malone open? She has lost weight and the thickness of the abdominal wall is 7 centimeters actually. Thank you.
Thank you very much, Dr. Santos. I think once in a while we face those severe constipation that don't respond to laxatives, and that's what I do. I switch them to enemas, and if they respond to enemas, then they are good candidates for Malone or Neo-Malone. There is a device that it's called Mini ACE. It's exactly like a G-tube, but it goes up to 10 centimeters in length. So that's exactly what you need. It's called Mini ACE. It looks exactly the same, but it has the big length that you need with a balloon, since Neo-Malones have more tendency to leak despite our attempts to create a valve-like mechanism. So can you go back to the contrast enema? I just want to show that when patients have severe constipation and contrast enema that doesn't show too much dilation, those are the ones that I mainly concern, because those are the ones that usually don't respond well if we try to do bowel resection. So the fact that's my algorithm for doses, we try stimulant laxatives. If they don't respond, I will go to enemas. If they respond to enemas, that's it. Treatment with enemas and antegrade enema procedure if the patient wants. But I just wanted to show this image because patients that don't have dilations, those are the ones that usually don't benefit much from colonic resection. So congratulations on your case. And I see there are many questions. Do you want to comment?
Yes, as you can see in this case, we still have lots to learn about colonic function. It's not only ganglion cells, no ganglion cells, idiopathic constipation with dilated colon, but there are cases like this for which we don't have an explanation as to why that colon doesn't move and yet is not dilated. We see something similar in patients with myelomeningocele. They don't develop those huge megasigmoids, and yet they have severe constipation. So these are very, very unusual and unexplained cases. Now, if you show the diagrams again, how do you make that colonic tube? That I didn't understand exactly why do you have to do the tube so long? Why not to move the cecum to the belly button? In other words, if you open more, you can separate completely the right colon and move it to the area of the umbilicus, and that way you can connect a relatively short neo-appendix.
The patient was chubby, the
Yeah.
abdominal wall.
Was very chubby. So I see that's another problem. Yes.
Yeah.
So,
11 centimeters of the wall.
The
Oh.
abdominal wall was 11 centimeters.
oh, I see. Okay. Now I understood.
So there is another question. When the rectal stool loading is relieved, lower urinary symptoms tend to disappear. Do you think it was the Botox or the constipation management that did the trick? Because the Botox effect wears off in about 3 months.
The result is for enemas, no? For management. There is a syndrome, vesico and intestinal symptoms.
Yeah, but originally you said that the patients had urinary incontinence, and I don't see how the Botox improves the incontinence. Botox makes relaxation of the smooth muscle. So it sounds more like being able to empty the colon. By doing that, you improve the function of the bladder. When the bladder is constantly compressed by the colon, the patients have frequent voiding or incontinence.
There is another question. How was the rectal biopsy performed? With a biopsy gun or manually? Did you do a full thickness biopsy or just a suction biopsy?
No, only submucosal biopsy. And the results were normoganglionic.
Okay. Let me see if there is any other questions. I think we answered them all. So I have another case, just so we have, the past meeting was total colonic ganglionosis. This one had a lot of complicated Hirschsprung. So I just wanted to show good Hirschsprung with a late diagnosis. Let me just see if I find the PowerPoint here. 1 second. Yes. Can you see my screen, Ray?
Perfectly.
Perfect. So this is a 2-year-old male patient that was born during the pandemic. So it was unclear if he passed meconium during 24 hours after life. So the mother was suspicious to have COVID. She had to stay away from the baby. At home, when the
No
patient
se
was...
escucha, Andrea.
Can you hear me?
Yes.
Okay. So at home, when the patient was discharged, There was no bowel movements and he started vomiting. So this is the initial contrast enema. Suction rectal biopsy was done and reported with ganglion cells present. The patient was then referred to GI, to the gastroenterologist, and prescribed daily glycerin suppositories with instructions to slowly space them out. When he was doing one suppository every 2 weeks, he was admitted in the intensive care unit, almost unresponsive, and treated aggressively for enterocolitis. A full thickness rectal biopsy was done that showed no ganglion cells, but creatinine positive. So he was instructed to do daily rectal irrigations. A new contrast enema was done, and here are the images. So the patient came to us because the local surgeon was not trusting the pathology reports. The parents were very confused too. And because of the confusion, because of not knowing where the biopsy was taking and the conflict result with ganglion cells and creatinine, we decided to do a full thickness rectal biopsy under direct vision so we knew exactly where the biopsy was taken. That's how we do it. We put the patient in lithotomy position. We put the Lone Star retractor just at the skin level. So we are seeing now the anal canal. And then we're going to advance the hooks. I don't know if you can see my arrow, but we're going to advance the hook to this area here, protecting the anal canal. So we only have now rectal mucosa. We are no longer seeing the anal canal. And then we use 1/5 silk of where we're going to do a biopsy, and we place 2 5/0 vicryls for the suture. And we do a 2-layer running lock suture. And we cut with scissors a big biopsy so the pathologists have enough tissue to give us the definitive response that we are looking for and that the family was looking for. So here's at the end of the biopsy, you can see that it's completely sutured. There is no bleeding. I always do a digital exam to make sure there's no stricture. And the biopsy results came back negative for ganglion cells, hypertrophic nerves, and creatinine negative. So this was compatible with Hirschsprung's disease. And then we decided to operate on the patient. Again, we put the patient now in prone position, the Lone Star hooks just at the skin level, and now we're going to advance. You can see where is the limit, so we're going to advance so we have the anal canal completely protected. Now we're just seeing rectal mucosa. That's where I'm going to put my 5/0 silk stitches for traction. And here we dissected the bowel. We did a biopsy, and at 15 centimeters, we had ganglion cells and no hypertrophic nerves. So this presentation was supposed to be from last month, and that's why I wanted to compare a rectal sigmoid case with a case of total colonic ganglionosis. So in a rectal sigmoid case, we can do the pull-through as a newborn. And if the anal canal is damaged, we can do bowel management with enemas to treat fecal incontinence. Many people confuse why in a total colonic ganglionosis, if the patient is fecally incontinent because of a damaged anal canal, why we cannot do bowel management. And the reason is there is no bowel management for the ileum. In order for the bowel management to succeed, we need to be able to form solid stool. And the small bowel is what absorbs the nutrients, so we cannot do enemas in the small bowel. So in a patient with rectal sigmoid that has been well operated, that the anal canal is preserved, I still have a strict protocol. I keep them NPO 7 days on TPN, and I let them go home doing rectal irrigations 3 times a day, flagell 3 times a day. This patient is now almost 2 months post-operatively. He's just doing once a day irrigation because he's stooling well. He's on laxatives, but he's having voluntary bowel movements. Any questions about this case? So there's a question, please answer if the suction biopsy is, I would say, is good for older children. In my case, I don't do suction biopsy in older children. I do full thickness biopsy. I want to know exactly where the biopsy was taken, and I want to send a very good specimen for the pathologist so there is no doubt. If I'm operating, it's because we have a precise diagnosis. So that's my, do you have any comment?
Yes, remember, it's extremely important that if you are going to operate on patients with Hirschsprung disease, you count with the collaboration of a very well-trained pediatric pathologist trained specifically in the diagnosis of Hirschsprung disease. So for some pathologists, it's not easy to make diagnosis of Hirschsprung disease based on frozen sections and suction biopsies. So if you have absolute confidence in your pathologist with frozen sections and suction biopsies, go ahead. But if you want to play it safe, you better take full thickness biopsies. And it's a short procedure with no complications, but it has certain details that we must follow during doing that, because we have seen complications by pediatric surgeons that have no experience in a full thickness biopsy.
Let me see if there's any other questions. I don't think so. Well, I would like to thank everyone that have joined. So again, we have pediatric surgeons from Uruguay, Romania, Nigeria, Trinidad and Tobago, Bosnia, Mexico, Iraq, Czech Republic, United Kingdom, Chile, Indonesia, Sri Lanka, Brazil, Spain, Venezuela, Saudi Arabia, Croatia, Colombia, Kosovo, Bahrain, and Rwanda. So thank you very much. Please send your cases for next month. We would love to see you again. Our next meeting is scheduled for July 13. So we hope you can join us. Thank you very much. Bye-bye.